You are welcome to workshop organized by Kurunagala Medical Association to win the battle against COVID-19. This workshop consists of 7 presentations done by experts in their field in investigations and optimal management of patients with COVID-19. We believe this workshop will definitely improve the knowledge, attitude, and skills of doctors who care these patients. Once you complete this workshop, you will receive a certificate of attendance. Thank you for joining us. Enjoy the presentations.
I am Dr. Lalith Abeywardana, consultant physician, teaching hospital Kurunagala. First of all, I would like to thank the Clinical Society of Kurunagala for arranging this training program on COVID-19. And you are welcome for the training program. I would like to talk on the overview on COVID-19 because this pandemic has a great impact on our day-to-day life and children's education and the country's economy. So having worked in teaching hospital Rathnapura in COVID wards, COVID ICU and in COVID steering committee, so I would like to share my experience with you. So as you know, so what is COVID-19? Coronaviruses, COVID are a large family of viruses that cause illness ranging from the common cold to more severe disease. So in the past, we had two epidemics of coronaviruses. So one is Middle East Respiratory Syndrome. It is MERS-CoV. It was known as Tamil flu. It happened in 2012. And the second one was Severe Acute Respiratory Syndrome, SARS-CoV-2 in 2002 to 2003. It was infected over 8,000 people from 29 countries, resulted in 774 deaths. So a novel coronavirus is a new strain that has not been previously identified in humans. As you know, it is a zoonotic disease and it was originated in Wuhan. This is the virus. It is similar to a crown. That is why it is named as coronavirus. The virus associated with the outbreak originated in Wuhan, China. It has been designated severe acute respiratory syndrome coronavirus 2 SARS-CoV-2. The disease caused by that virus is now officially called COVID-19. So there are various protein spikes on the virus like spike glycoprotein, membrane protein, nucleoprotein, and it is an RNA virus. So the National Epidemiological Report Sri Lanka usually gives the report daily saying the number of confirmed cases and the number of home-based patients, recovered patients and total deaths. So it is updated daily. And according to the epidemiology unit, Ministry of Health, the chart shows there are three waves. So the first wave, second wave and three waves. Now we are facing the bad third wave now causing lot of damages to the country and to the people. And this is the natural history of COVID-19 infection. So at the time of symptom onset, in the first week of the illness, so we can see the peak viral load, especially in the upper respiratory tract. And highest infectivity is seen just before or within the first 5 days of symptom onset. So RT-PCR tests can detect viral SARS-CoV-2 RNA in the upper respiratory tract for a mean of 17 days. Symptomatic or pre-symptomatic transmission 1 day before symptoms onset is likely to play a greater role in the spread than asymptomatic transmission. So there are various stages. The first one is asymptomatic phase. COVID symptoms can vary from person to person. 80% of people may show no symptoms at all and vary in severity due to underlying health conditions like the patients with CKD, diabetes mellitus, and other immunosuppressive diseases. The day 1 symptoms will start between days 4 and 5 after the exposure. So fever is the most important physical symptom. As in other viral infection, temperature is around 100 Fahrenheit or greater. So the main symptoms are dry cough, shortness of breath, loss of smell or taste. Many people go from 2nd to 14 days with minimal symptoms. From day to 2 to 10, mild to moderate illness lasts for about 7 to 10 days. Fever, cough and fatigue, upper respiratory symptoms and digestive symptoms are more common. But most patients recover from this phase. But worsening symptoms can be seen in the second week, and breathlessness on severe exertion is the most important symptoms. That is the early symptoms of severe COVID. So that should be detected early. And day 10 to 12 in severe COVID pneumonia, so most of them are oxygen dependent. They need ICU and HDU management. Due to ARDS, extreme difficulty in breathing require ventilator support. The Centers for Disease Control and Prevention does not. ARDS diagnosis typically happens between day 8 and 12. Sometimes it occurs as late as 15 days after the symptoms. But onset of difficulty in breathing may be sudden, but you have to think of other causes also for sudden difficulty in breathing. Day 10 to 14. With mild COVID 19, they begin to feel better. Symptoms will start to subside. Cough will last an average of 19 days. But that is not the end. But some patients develop post COVID syndrome involving respiratory, gastrointestinal, neurological, musculoskeletal, and all other systems. And you can see this chart. You can see the exposure to the patient and pre-symptomatic phase and the viral load and the onset of mild to moderate illness and severe illness, and some patients will develop or will go into critical illness. So the mild moderate illness usually start from day 1 and lasts for 10 days, and some of them, not all, will get severe illness and they will develop the exertional shortness of breath, and some will develop critical illness requiring ICU admissions and ICU care. So antibodies start to increase from the day 3 and it gradually increases. This is a simple thing. When going to a healthcare facility of any kind in areas where COVID-19 is spreading, you should do these 3 things. Maintain a distance of at least 1 meter from the others, clean hands frequently, and wear a mask. And if you see this graph, you can see there are 3 phases: the time course and disease severity. Then the first stage is known as the early infection, the second stage is pulmonary phase, then stage 3 is hyperinflammation. So in viral phase, the typical feature is lymphocytopenia. But in stage 2, so they will develop abnormal chest symptoms or they will develop pneumonia. So you can see abnormal chest x-rays. And in stage 3, it is hyperinflammation. Although the inflammation is a beneficial thing to the body, but sometimes they develop host response. So elevated inflammatory and cardiac biomarkers. Sometimes cytokine storm is seen, causing multi-system failure or involvement. On clinical classification, there are 5 stages. The grade 0 is asymptomatic patients, individuals without clinical signs. In grade 1, mild type, outpatients and patients with mild symptoms of upper or respiratory tract infection. The grade 2 moderate type, patients requiring hospitalization with lobar or multilobar pneumonia with or without the need for oxygen or refractory to initial treatment. Grade 3, it is severe type, patient who need ICU care, mechanical ventilator support or with ARDS or non-pulmonary involvement. Grade 4 is very severe or critical, patients who need immunomodulatory therapy or with multi-organ failure and or cytokine storm. So Dr. Richard Leviton gave an important concept. He is an emergency consultant. And there are three areas. The first area in gray shows oxygen saturation is normal. Patients don't have shortness of breath. They may have mild symptoms and other symptoms without shortness of breath or especially exertion shortness of breath. So then this is the time you have to detect exertional dyspnea. So for that what you need is just a simple pulse oximeter. So this test can be done at home or in intermediate care center. So big yield but less resources needed. So patient may develop exertional dyspnea. So by doing exercise test, you can detect the hypoxia. So you have to detect this hypoxia at this point. So by this point, patient is getting interstitial pneumonia, but patient may have mild symptoms. So then if this is left undetected, so patient will go into the blue colored area. So it is the zone for hypoxia. So in this phase, they usually present with hypoxia at rest. So they need oxygen, high flow, nasal oxygen, CPAP, patient positioning and proning. So then some of them go into the high mortality zone or red colored area. They need intubation, ventilation, sedatives, pressure support, IV, pump, central line, etc. So some of them will develop thrombosis, renal failure and neurological injury and multi-organ failure. And the test is called modified exertional desaturation test, MEDT. So after 10 steps test, as it will be discussed later, so you can detect silent hypoxia. So for that you need less resources, but you need the center or place to keep patients like intermediate center, and you need the basic instrument like pulse oximeter. And if the patient is in red zone, you need big resources like HDUs, ICUs, high flow, CPAP, and lot of other interventions. And resource allocation is important in an epidemic. So from the emergency department, OPD and admission, so COVID rat positive patients should be admitted directly to the COVID wards. So for that, the rat should be done in emergency department. But there are practical problems. But from the emergency department, patient can be discharged for home quarantine or can be sent to intermediate care centers. And then suspected patients, rat negative, and can be sent to a ward till the PCR report is available, and then if negative can be sent to normal wards. And from COVID wards, they can be sent to level 2 in other hospitals, or one ward should be equipped with HDU, high flow nasal oxygen and NIV facility with wall oxygen, and then you can downgrade or you can upgrade. And it is cost effective. If COVID rat test can be done for all patients at OPD emergency level, so wastage of resources can be minimized. So there are practical issues because of the staff allocation and the other facilities and space, etc. But by doing that, so we can reduce the number of PPE, the cross infections can be minimized, and staff exposure and number of investigations, practical issues for imaging, and cost for partition, staff room, change in rooms, sharing toilets, allocation of staffs. So those can be minimized if we can do rat test in the emergency department. One mode should be upgraded to HDU, providing whole oxygen, NIV, and negative pressure and adequate trained staff. And complications of COVID-19 and will be discussed by another speaker. So I would give a summary. Respiratory system involvement, interstitial pneumonia, lung fibrosis, coagulopathy, cardiovascular manifestations like myocardial infarction, myocarditis, cardiomyopathy, and kidney involvement, hematological, electrolyte imbalance, liver involvement, endocrine involvement, CNS involvement, ocular manifestations, and multi-organ failure. And the management of COVID pneumonia, complications, treatment modalities, supplementary oxygen, and post-COVID syndrome will be discussed in other lectures by other speakers. Thank you.
Hospital discharge of asymptomatic or mild symptomatic COVID-19 patients for home-based isolation. I am Dr. Barana Millawithana. I am the consultant physician of Emergency Treatment Unit of Provincial General Hospital, Kurunegala. During this talk, I would like to talk the rationale of home-based isolation. I would like to discuss a case scenario, and I would like to tell you how to select correct patient for the discharge and how to ensure the process safe to our patients. The third wave of COVID-19 in Sri Lanka started in April with the Alpha variant. Currently, we are experiencing the second peak of it with highly transmissible Delta variant. So, exponential increase of number of individuals becoming positive and increased number of severely ill patients were observed. The impact on healthcare delivery system and community was very, very significant. The hospital bed capacity was exceeded, as well as intermediate care centers were full of patients. This is the statistics of our hospital during last few weeks. Starting from 1st of August, you have seen the increased number of patients, the total number of patients, as well as number of oxygen dependent patients. So by about mid of August, we had almost 280 patients in the hospital, as well as we were getting about 30 to 40 patients per day who are having COVID-19 symptoms. And this time, the Ministry of Health has issued a guideline allowing us to send these patients to home-based isolation and management. We were able to start the home-based discharge from 13th August. You can see it has big impact. It plateaued the curve, which was ever increasing before that time. And if you see the second graph here, you can see the yellow bars are the daily discharges for home-based care. Is it beneficial? Yes. So it is beneficial to healthcare services as well as patients. Thinking about healthcare services, it helped to reserve hospital facilities to incoming symptomatic patients, as well as optimal utilization of available facilities to moderate severe ill patients. A patient's aspect, everybody like to stay at home, because if they are asymptomatic or mildly symptomatic, the home is the best comfortable place for a patient. So I would like to discuss a case scenario. This is a 21-year-old female admitted on the day 2 of her illness. And on admission, she had fever, cough, myalgia, and diarrhea for 1 day duration. She has strong contact history with COVID-19 positive patients at her workplace, and she had received first dose of Covishield vaccine 2 weeks prior to her admission. She is a diagnosed patient with diabetes. It is latent onset diabetes in adult and well-controlled diabetes on basal bolus regime. However, she didn't have any diabetic-related complications, or she didn't have any other comorbidities. And she lived with her parents and siblings, and she had adequate social support to be at home during her COVID-19 illness. And this was her on-admission triage findings. So when she came to A&E, her triage shows she has respiratory rate of 12 and saturation was 98. Her heart rate was 118 and blood pressure was 94/56, and her other parameters were okay, except tachycardia, which putting her to the triage category 3 in A&E. All the parameters were normal. An initial blood investigation, she was anemic, and her CRP was okay, and her renal functions was okay with mildly deranged electrolytes with slightly raised liver functions. And she was admitted to a ward, and day 3 of the illness, she was discharged for home-based management. Day 6 of the illness, this patient readmitted with worsening of shortness of breath for 1 day duration. An A&E triage on day 6, the admission, the second admission, she was in respiratory distress. Her respiratory rate was 36, her saturation was 94 on air. She was extremely tachycardic with 140 and blood pressure was 90/60. ECG shows sinus tachycardia and blood sugars were okay. And her blood investigation sent at A&E showed neutrophilic leukocytosis with WBC 12,000, increase in CRP, and troponin was elevated, and her liver functions was elevated than previous, but her renal functions was okay. And she was resuscitated and managed at A&E, and this was her chest X-ray on the second admission. It has the bibasal consolidations, which sounds like she has COVID pneumonia. And CRP was rising to 100, and her procalcitonin was high, 1.09. Troponin was almost stable, and her liver functions was in thousands, and LDH same, and the ferritin was extremely high, so COVID pneumonia with sepsis, and she was resuscitated and managed at ICU. However, unfortunately, day 8 of the illness, she was succumbed due to the severity of the illness. Okay, after going through the case, discharge for home-based care, is it harmful to the patient? And the mortality review and the learning points from this case is helpful to improve our home-based care planning. So, usually home-based care is beneficial, as I said. But if we don't select the correct patient, and if we don't do the correct discharge planning, it can be harmful to the patient as well. And we have to carefully plan the discharge, as well as we have to educate the patient, and there are information leaflets to the patient, which is really helpful to the patient when they're at home to follow. And patient should be handed over to the community team, and there is a proper system for follow-up. As well as we have to inform the patient as well as community team what are our escalation or de-escalation plans for that patient. So if we follow these steps correctly, we can utilize this home-based care is very effectively to preserve our healthcare facilities for needy patients, as well as we can ensure the safety of the patients who we discharge home. So home-based discharge care planning. How are we going to select right patient? So Ministry of Health guideline has given definition. Who are the patients appropriate, or who are the patients should we consider for discharge? First is asymptomatic. What do you mean by asymptomatic? Patient's PCR or RAT positive, no symptoms, and resting saturation is more than 96. And other category is mildly symptomatic. So patient's PCR RAT positive, patient is having respiratory symptoms with or without fever, and may be associated other symptoms like diarrhea or body aches, myalgia, such symptoms. The important thing on the discharge, patient should not have shortness of breath either at rest or even mild exertion. That is very important. This can be objectively assessed with modified exertional desaturation test. So before discharge, this mild symptomatic patient, their resting saturation should be more than 96 and should not drop below 94 after defining the patients, like it is either asymptomatic or it is mildly symptomatic. Then we have to think what is the severity of the illness of this patient. But who are the patients suitable for home-based care? Either A&E category 4 patient or severity grading with this use in COVID wards, level 1 patients. After considering the such patients for home-based care, what we have to do, we have to carefully assess the patients. So we have to take proper history, focus examination, and appropriate use of vital signs. Any patient who's having atypical or warning symptoms or unusual features in history are not suitable. Abnormal physical signs, including vital signs, abnormal laboratory investigations are not suitable for home-based care. And all the patients, after deciding with the history, examination, and assessing the vital signs, we have to perform modified exertional desaturation test for all these patients. And other thing, most important thing, nowadays, there are patients coming with dengue or leptospirosis or any other infectious diseases. As the community burden of COVID-19 is very high, they are rapid antigen or PCR positive, and they are having co-infections. Always we have to exclude the alternative diagnosis. If junior doctors, if you have any doubt, please seek the senior opinion before discharging such patient who's having a doubt in your mind. Make your decision. Ministry has given this checklist. In the hospital, we have made this form is mandatory to be filled before sending a patient. So that checklist says, and you have to tick yes or no in each and every box. If any box says yes, you should take the senior opinion. The next thing is warning signs. If any patient who's having these warning signs like ongoing fever, the debilitating symptoms, excessive shortness of breath, altered mental state, chest tightness, should not send home. And comorbidities, very important, because we have seen the COVID-19, patient with diabetes, patient with hypertension, patient with CKD, their mortality is high. So these patients, if you are sending such patients or any other comorbid conditions like active malignancies or these patients with immunosuppression, we have to make extra precaution before sending these patients home. We have to plan the discharge and how are we sending the patient home. And we always give a leaflet to the patient and ask them to clearly read and understand. And most importantly, it gives a lot of facts, what to do and when to admit, when to call for help. So most important thing is these warning signs. We have to tell the patients, if you have these warning signs, please come to the hospital as soon as possible. As well as it has given the numbers to call when you need the help. And patients education wise, there are do's and don'ts. So that also important. So what are the pharmacological things you can give? Just symptomatic things. No other specific drug needed to these patients. As well as patient has to maintain their rest, fluid balance, as well as nutritious diet. And comorbidities wise, very important, you have to go through the drug list before discharge, carefully assess what are the drugs patient should continue, what are the drugs which can harm the patient. So you review the drug list of the patient and inform these drugs are very important. You continue these drugs, as well as most of our patients, they are having the diabetic patient glucometers, sometimes digital blood pressure apparatus, and they are having pulse oximeters. They can do the modified exertional desaturation test by themselves. And next thing is we have to hand over the patient to community team. So this the table has given to all the wards where COVID-19 patients are in the hospital. So the responsibilities on the nursing officers or the house officers, any patient you discharge from your ward for the asymptomatic or mild symptomatic patients for home-based care, please fill their name, address, MOH area, BHG number, and mobile. Same day, put the date, and send this form to the infection control unit of the hospital. So, in summary, the home-based management of patients with mild or asymptomatic COVID-19 infections is beneficial to both healthcare system and patients. But we have to carefully select the patients whom to be discharged because it can be harmful to the patients as well. And we have to adhere the guidelines, as well as we have to use our clinical judgment to properly assess the patients with the history, with the examination, careful use of machine parameters, as well as modified exertional desaturation test before sending home. Please educate your patient and empower the patient before sending home, as well as talk to the patient and inform their safety issues, how to keep the patient, keep the community as and the home safely without transmitting the infection from the patient to the other. And the handing over the patient to the public health team is mandatory for their remote monitoring system, as well as continuation of care for the patient. Thank you very much.
Welcome you all. My name is Dr. Sriyantha Adhikari. I am the emergency physician at the Provincial General Hospital, Kurunegala. During next 20 minutes time, I will be discussing about initial assessment and management of COVID-19 patients in emergency department and their transport out of emergency department. When patient comes to the emergency department, a nurse who is wearing full PPE will triage the patient. During the triage, patient's pulse, blood pressure, heart rate and oxygen saturation will be recorded. In addition to that, a risk assessment form will be filled at the triage. This is our usual triage sheet. Patient's pulse rate, blood pressure, respiratory rate, oxygen saturation and conscious level will be recorded in this sheet during the triage process. In addition to usual triage sheet, we are using a special fever and respiratory triage for all the patients come to the accident and emergency unit. There we are recording the informations about patient's symptoms like fever, cough and COVID contact details as well. After the initial triage, then the patient will be assessed by a medical officer. He will assess the patient using focus history, relevant examination and available investigations. By the time doctor sees the patient, doctor will receive the parameter recordings from the triage too. On admission, we obtain relevant history from the patient or bystander. As you know, the COVID incubation period can range from 1 day to 14 days. However, average is 4 to 5 days. Therefore, asking about contact history and exposure history for 14 days period is important. Most patients present with symptoms like fever, cough, fatigue, sputum production, shortness of breath and myalgia. There are some patients present with gastrointestinal symptoms as well. Patient's symptoms vary depending on duration of illness. There are no symptoms during the incubation period, and the patient experiences slow onset of symptoms during the first week of illness. He or she will get prodromal symptoms. However, 80% of patients will improve at the end of first week. During the second week of illness, symptoms will get worse. Therefore, during the history taking, it is important to ask about the onset of symptom and date of positive rapid antigen or PCR test. Vaccination reduces the severity of illness, morbidity and mortality. Therefore, it is important to know the vaccination date and completeness of vaccination process. Comorbidities. Patient with comorbidities carries worse outcome. Patient with uncontrolled diabetes, chronic renal disease and other immunocompromised status get the worst outcome. Chronic respiratory illness also have poor outcome. Therefore, it is vital to get the details of comorbidities and their medical control. Those patients with poor control need special attention and care during the COVID management process. We do relevant clinical examination in the A&E for the COVID patients. Patients with morbid obesity carries bad prognosis. Pale, cyanotic patients and patients with reduced conscious levels need special attention as they are having high risk of getting complications. Pulse rate and blood pressure parameters are used to categorize the patient. Other important assessment during examination is work of breathing assessment. Patient's position, whether it's in tripod position or sitting, lying down, and respiratory rate and depth, and use of accessory muscles for respiration, especially use of neck muscles and use of abdominal muscle for breathing indicate the magnitude of work of breathing. If the work of breathing is high, that patient has high chance of getting seriously ill and being complicated. Pulse oximeter is an important tool we use during the assessment of COVID patients. All the suspected patients' pulse oximeter reading will be recorded and used for patient categorization process. COVID-19 patients are categorized into three main categories, that is level 1 who are asymptomatic or mildly symptomatic, level 2 patients are moderately symptomatic and they need oxygen at some time, level 3 patients are very ill and they have severe symptoms. Level 3 patients are oxygen dependent. This is the guideline issued by Ministry of Health for categorization of COVID patients. Level of severity is categorized as mild, moderate and severe, which is equivalent to level 1, level 2 and level 3. Categorization based on respiratory rate, heart rate and oxygen saturation. If patients respirated below 20, heart rate below 100 and on air oxygen saturation above 94, then that patient belongs to mild or level 1 category. If the respiratory rate between 20 to 30 and heart rate between 100 and 120 and oxygen saturation between 90 to 94, that patient categorized as moderate or level 2. If the heart rate is above 120, respiratory rate above 30 and oxygen saturation below 90 on air, those patients will be categorized as severe or level 3. The patient management process will depend on patient level of severity. However, the level of severity can change later with the progression of illness. This is the definition for asymptomatic and mildly symptomatic patients given by Ministry of Health. The asymptomatic means PCR or RAT is positive and no symptoms, but his oxygen saturation is more than 94 at any time. Mild symptomatic means PCR or RAT positive. The mild upper respiratory tract symptoms are there, but all the time their saturation is more than 96%. Case number 2. A MOH refer 57-year-old male to A&E due to increased shortness of breath. He is tested positive on the same day at a private sector. Patient is having a medical history of mild chronic kidney disease. On triage, pulse rate is 102, blood pressure 160/90 and respiratory rate is 22 per minute. Oxygen saturation is 94 on air and saturation dropped to 91 with short distance walking. That is from wheelchair to bed. So what is the level of severity of this patient and what is the initial management for this patient? Again, we can use this chart. Patient respiratory rate is 22 breaths per minute, heart is 102 beats per minute and on air oxygen saturation is 94 and it drops to 91 with mild exertion. With these parameters, this patient is belong to level 2. He does not need oxygen at rest, but he needs oxygen with exercises. Initial management of level 2 patients. Level 2 patients need to manage in the hospital. Their oxygen saturation should be maintained above 94%. If saturation dropping below 94%, then they should be treated with supplementary oxygen. Initially, we can use nasal prongs to supply oxygen and then go for face mask, non-rebreathing mask and above depending on patient's oxygen requirement. Those who need oxygen or belong to level 2 needs investigation. Full blood examination, C-reactive protein and chest X-ray is the basic investigation for them. They may need some other investigations based on their comorbidities. For an example, our patient is known to have chronic renal disease. Therefore, a serum creatinine will be indicated here. Again, these patients need hospital admission, in-ward assessment and treatment. A patient who needs oxygen will be treated with triple therapy. That is intravenous antibiotics, intravenous steroid, subcutaneous enoxaparin. Shall we move to the case 3? A patient transferred to A&E from local hospital with oxygen via non-free breathing mask. She is COVID positive, day 8. Past medical history: diabetes, hypertension and dyslipidemia. On triage, oxygen saturation was 90% with non-free breathing mask. Pulse rate 120 beats per minute, blood pressure is low, 80 by 55 millimeter mercury, and respiratory rate is 30 per minute. So, what is the category of this patient and what is the initial management for this patient? Again, we use this chart. Respiratory rate is 30 breaths per minute and pulse rate 120 and oxygen saturation is 90 with oxygen. Therefore, patient belongs to level 3 or severe category. In addition, she is having multiple comorbidities too. These type of patients need special investigations and specialized treatment. They may need HDU or ICU care. However, due to shortage of HDU, ICU, these patients are often treated in general COVID wards. Initial management of this type of patient needs supplementary high flow oxygen to maintain saturation above 94. They may need special positioning to improve oxygenation. Maintain good hydration and nutritional state is very important during the treatment of these patients. These patients are often septic. Therefore, their blood pressure is low. We should treat these sepsis too. Fluid resuscitation with normal saline and inotropic support with noradrenaline is needed depending on the patient's condition. These patients are treated with triple therapy initially. However, these patients need special investigations to assess their disease severity and decide on further treatment option. It is better to admit them to HDU or IDU facility if available. Initial investigations for level 3 patients. They need additional investigations depending on their comorbidities. So, they need full blood count, CRP, liver function test, serum electrolyte, serum ferritin, procalcitonin level, blood culture, arterial blood gases, chest X-ray, ECG and D-dimer. These are the basic investigations we do for level 3 patients. As I mentioned earlier, these level 3 patients need specialized care and assessment. They may need advanced respiratory support like intubations and ventilation. Furthermore, they may be treated with new agents like IV tocilizumab. Then we move to the transport of the COVID patients. We do transport these patients from A&E to wards or A&E to some other units. So, how do we transfer them safely? Once we assess, investigate and initiate treatment for COVID patients, we need to transfer them to other units for further management. It may be general COVID ward, COVID HDU or COVID ICU. Sometimes we must transfer to these patients to other institutes like Kothalawala Hospital or somewhere in Colombo. So, what are the important aspects to be considered in the COVID patient transport process? One important thing is communication with receiving unit. We need to contact the receiving unit and inform the patient's condition and requirements. Then we must make sure that required facility is available in receiving center before the patient transfer. For example, if the patient needs 10 liters of oxygen per minute, the receiving unit should be able to supply that. A second thing to be considered is that patient should be stable enough for the transfer. We are not going to transfer a patient with oxygen saturation around 60. We need to optimize patient before transfer to another unit. We optimize as much as possible. The vital parameters should be within acceptable range before the transfer of the patient. Other one is equipments. Transport equipments need special attention, especially oxygen supply. We need to make sure that oxygen in the cylinder is enough to the transport period. Oxygen regulators has meter and it indicates the pressure inside the cylinder. If the cylinder indicator is in red zone, as in this picture, that cylinder is almost empty. That cylinder should be replaced before transfer. The equipments used for transfer are electrically operated devices. Once you remove them from wall plug, they run by internal battery. Some equipments are old and battery will drain soon, leaving the equipments non-functional. So we need to select good equipment for transfer. Furthermore, patients can deteriorate during the transfer. Therefore, we need to carry required medicine and resuscitation equipments like ambu bags and medications. Other factor is personals. The accompanying personnel should be capable of managing the patient during the transfer. Sometimes unexpected deterioration will happen and transfer team must manage those conditions with limited facility during the transfer. Therefore, accompanying team should be capable team. When transferring COVID patients, accompanying team should wear adequate PPE because patient may deteriorate suddenly and then there will be no time to wear PPE. The mode of transfer. Mode of transfer should be decided before initiation of actual transfer process. Time and route of transfer is another important thing in the patient transfer. The left-sided corridor in this picture is not suitable to transport a COVID patient, but right side corridor is less crowded. Then the transfer should be easy and safe. When we transfer patient to the faraway locations or other institutions, we need to select time periods with less traffic in the roads. For example, transfer during the night. That's all. Thank you for listening. I will be happy to answer any question at the end.
Welcome you all for this forum. I'm Dr. Muditha Abeykoon, consultant clinical microbiologist, Peripheral General Hospital, Kurunegala.
And I'm going to talk about mainly the COVID-19 current discharge criteria. I think you might have already
listened to several lectures on COVID-19 infection, mainly the clinical aspect and also the diagnosis part. But I'm basically going to talk about current COVID-19 discharge criteria. Discharge criteria for patients in COVID wards. So if you want to discharge the patient, we have to consider several factors. One of the main factors is whether this patient is immunocompromised or not, because the discharge criteria for immunocompromised patients is very different from non-immunocompromised patients. Then you have to see whether this patient is having mild to moderate COVID-19 infection or a severe COVID-19 infection. Now, we will see, I think we need to know or we need to refresh our knowledge about immunosuppressed patients. So, who are the immunosuppressed patients? The number one is organ transplant recipient on immunosuppressive therapy. So, if you take Kurunegala district, mainly the renal transplant patients who are on immunosuppressive therapy. Then the second category is bone marrow transplant recipient, if the bone marrow has been performed within past 2 years. Third one, the cancer patients undergoing treatment or patients who are having active malignancies. Fourth one is those on long-term immunosuppressants or corticosteroid for any reason. Another one is HIV-infected patients with CD4 T lymphocyte count below 200. But nowadays, usually, most of HIV-infected patients are on treatment and their CD4 count is more than 200. So if the CD4 count is more than 200, we don't take them as immunosuppressive patients. Another one is patients with primary immunodeficiency. That is, if you are having some sort of a severe immunodeficiency from birth or due to your defect in your immune system, we take them as primary immunodeficiency status. Any other condition decided by the treating consultant. So first we have to see whether this patient is immunosuppressed or not. Then we have to see whether this patient is having a mild to moderate disease or severe disease. So what is a mild COVID-19 infection? So mild COVID-19 infection is defined as individuals who have any of the signs and symptoms of COVID-19 like fever, cough, sore throat, malaise, headache, muscle pain without SOB. So in simple terms, patients who are having upper respiratory tract infections due to COVID-19 infection. The moderate illness is defined as individuals who have evidence for lower respiratory tract disease or evidence for pneumonia by clinical assessment or imaging, that is either CT or X-ray, and the saturation of oxygen shouldn't be fallen below 94 on room air. So basically patients who are having pneumonia, but their saturation is not falling below 94 on room air. So severe illness is defined as individuals who have respiratory frequency more than 34 minutes with excessive use of accessory muscles and thoracoabdominal dyssynchrony, or SpO2 is less than 94 on oxygen, even on oxygen, and for patients even on oxygen. And also if PaO2 to FiO2 ratio is more than 300, that if it is severe ARDS, so lung infiltrates in the chest X-ray is more than 50. In severe illnesses, there is another category where they are having a critical illness. This is whom the patients who have respiratory failure with septic shock or multi-organ dysfunction. So when you assess a patient in COVID-19 ward, first you have to see whether the patient is immunosuppressed or not. Then you have to see whether he is having a mild illness, moderate illness, or severe illness, because it is very important, because not only for the treatment or the management of the patient, but when it comes to the discharge, the initial status of the patient is very, very important. Now let's see how we are going to discharge these patients. So COVID-19 patient who is coming with mild to moderate illness and they are not non-immunocompromised. So according to the current guidelines, all of these patients should be in a COVID ward for at least 10 days. And here I have to mention about 1 month ago, because of the large number of patients we are encountering in the community, the Ministry of Health took a decision. Under this category, if the health authorities, that is the MOH and the relevant doctors, are happy to keep them in a house or in their own home, and they can be managed under the guidance of a medical officer. If we decided to take it to a hospital, we have to keep them in for at least 10 days. And after 10 days, if the patient is afebrile for more than 24 hours with improved symptoms, and if the MEDT is negative, that is modified exertional desaturation test, which is I am not going to describe here. Probably you might have learned in this one. You might have learned about this one in your previous lecture. So you can discharge this patient after 10 days of the onset of symptoms, or if clinically fit. If you don't know the onset of symptoms, take day 1 as the day that the PCR became positive. The main important thing here is you don't have to perform a RAT or a PCR test to discharge these patients. Under the second category, still they are non-immunocompromised, but they are this time having a severe or critical illness. So they are having a pneumonia in a severe way. So these patients should be in a COVID ward for at least 14 days. At 14 days, if the patient is afebrile for more than 24 hours with improved system, if he is clinically fit, and if the MEDT is negative, then they can be discharged 14 days after the onset of symptoms if clinically fit. So in summary, the patients who are having severe pneumonias, even though they show any sort of improvement, still you have to keep them in for 14 days. And after 14 days, if they are clinically fit, you can discharge without performing a RAT or PCR. Now let's see what is the current discharge criteria for significantly immunosuppressed patients. I think about 5 minutes ago, I described about these examples about the severe, who are the immunocompromised patients. So all the immunosuppressed patients, whether they are having COVID-19 upper respiratory tract infection or whether they are having COVID-19 pneumonia, we have to keep them in a ward for at least 14 days. And like the above category, if they are clinically fit at day 14, you can think about discharge them, but you have to perform a COVID-19 PCR test on day 14. And if it is only negative, you can discharge them. If the PCR is positive on day 14, then you have to see what is the CT value. If the CT value is more than 30, perform another PCR test following day. And if the CT value of that test is also more than 30, this patient can be discharged. Otherwise, you have to keep this patient in for at least 21 days. So after keeping the patient in for 21 days, if the patient is clinically fit to go, if the patient's clinical condition has improved, you have to perform 2 consecutive rapid antigen tests, and these rapid antigen tests should be negative. The basic point here is, it is found immunosuppressed patients can significantly excrete mutant strain. So if we are going to discharge these patients, there is a risk that they might be spreading mutant strains to the community. So that is why we are keeping immunosuppressed patients for a longer duration in hospital, and also we are performing a PCR or RAT to make sure that they are not non-infectious. So I think that is the main thing I have to highlight on the current guideline for discharging the patients. Again, one thing I need to emphasize you, we need not to perform PCR or the RAT test on patients who are having even severe disease or non-immunosuppressed patients, because it is found you can find a lot of positive PCRs on COVID-19 patients even after several months they are having the disease. So if you are going to perform PCR test and if you are going to evaluate the results, you won't be able to, you may have to keep this patient in for several months. So the basic point here is, if we are sure that this patient is non-infectious, you don't have to worry, you can discharge these patients. And other important thing is, we all know now the disease has a very significant community spread in Sri Lanka. So as a result, I mean, there is a theoretical risk that we might discharge one patient who is actually infectious, 1 or 2 patients who are actually infectious, but it won't affect the whole cycle. There is another one component I want to emphasize on this lecture, that is, when you are managing COVID-19 patients in a COVID ward, I think the current practice is those COVID-19 patients are actually, we have put several partitions and the medical health staff is in a separate position, and they are, the patients, COVID-19 patients are actually separated from the healthcare staff. That is for our own safety. But please remind, these COVID-19 patients also can get complications. So your clinical vigilance is very, very important. Though they are managing these patients, usually though you are managing these patients from a distance. So because of that, I need to highlight some of the complications actually I have seen in this COVID-19 patient. The first thing is, the most common complication is, as you all are aware, COVID pneumonitis. So these patients are coming with severe respiratory distress. So you have to assess according to the clinical parameters how severe the severity of the pneumonia, and you need to manage these patients accordingly. The second thing is, there is another category. Actually, with the initial oxygen treatment, these patients show signs of improvement, but keep an eye, because sometimes they show signs and symptoms of improvement. Suddenly, they can deteriorate. So even patient who seems to be improving from COVID-19 pneumonitis, still you have to keep an eye on them because suddenly they can deteriorate. The third one is, I have seen some young patients, actually they are not coming with any COVID pneumonias, but suddenly they can develop very severe massive myocardial infarctions, and some patients can develop thromboembolic phenomena, thromboembolic events. The last one is, you all know we use steroids heavily to treat severe COVID-19 infection. But you should know when to stop steroids, because unnecessary usage of steroids can lead to secondary bacterial and fungal infection. So these secondary bacterial and fungal infection sometimes be very challenging to treat. So the take-home message is, you have to keep an vigilant eye, though you are managing these patients at a distance. And other thing is, don't be complacent that even the patients who show signs and symptoms of improvement, still you have to keep a vigilant eye, because you can develop late complications as well. During my lecture, I covered two main areas. Number one is current discharge criteria, and the second one is, if you are managing a patient in a COVID-19 ward, what are the complications you anticipate? Before finishing my lecture, I just want to give you all a message, because there are several predictions about the current COVID-19 pandemic. And the main question is when it is going to finish. But unfortunately, I don't have a very good answer to give it to you, because all the predictions are suggestive of that this pandemic is going to stay with us for several years. We all know the main two weapons to control this pandemic is social distancing and vaccine. Social distancing is mainly achieved by lockdowns, and the vaccines we use to prevent the disease. But it is quite evident now, vaccine only prevents severe disease, but it never breaks down the transmission cycle completely. So because of that, we will see for many more years to come, we will see a lot of people who are going to get infected with COVID-19 infection, and unfortunately, some of these patients also will die. Meantime, we will see our daily medical and surgical cases as well. So in future, we have almost all the hospitals in Sri Lanka should be get ready to manage not only the COVID-19 infection, but also the other medical and the surgical condition as well simultaneously. Because of that, if you want to combat this deadly bug, I think the consultants, doctors, and other healthcare staff, we should work as a team. Otherwise, we won't be able to minimize the damage which is going to cause by this deadly bug COVID-19. Thank you very much.
Hello, everybody. I'm Dr. Herath, consultant anesthetist. On behalf of the Department of Anesthesiology, I'm here to present a lecture on oxygen therapy equipment. My presentation is on equipments used in oxygen therapy. In my presentation, I'll be talking how to improve oxygenation, then assessing oxygenation of a patient. I'll be discussing oxygen availability and storage of oxygen, equipments used to provide oxygen, and there will be a video demonstration on how to supplement oxygen. What is oxygenation? Oxygenation is transfer of oxygen in the alveolus into the blood at the lung level. How do you improve oxygenation of a patient? Two ways. One, by increasing partial pressure of alveolar oxygen. This can be done by supplementary oxygen from 21% to 100%. Two, by increasing surface area of the alveolar capillary membrane available for the gas exchange. This can be achieved by providing continuous positive airway pressure and positive end expiratory pressure. How do you assess the adequacy of oxygenation of a patient? Clinically, we can assess it. Cyanosis of mucous membranes and signs and symptoms of autonomic stimulation. But these signs may be too late to catch. But if you can measure arterial oxygen saturation by pulse oximeter or partial pressure of arterial oxygen by using arterial blood gas analysis, this will be more objective methods of assessing one's oxygenation. Using arterial oxygen saturation by pulse oximetry is more practical as it is non-invasive, freely available, continuous, but it is also prone to errors, and we have to make sure our what we read is not wrong. In pulse oximeter, normal saturation is between 95 to 99%. In oxygen therapy, our target saturation is between 92 to 94% with minimum oxygen concentration that can be provided. In respiratory triples with COPD or in third phase of COVID, revised targets are used, that is saturation of between 86 to 90%. So I said we have to ensure good pulse oximeter waveform to get a correct reading. The first wave shows a normal pulse oximetric waveform. So anything other than this first waveform can give you erroneous readings. In that case, adjust the pulse oximeter probe so that you get a good signal and a correct reading. Let me explain oxyhemoglobin dissociation curve that we had been using for a long time. There are three important points. When partial pressure of arterial oxygen is 100, we get a saturation up to about 99 to 100%. When the venous point is concerned, when the partial pressure of arterial oxygen is 40, our saturation is 75. And when the partial pressure of oxygen is 60 millimeters of mercury, we get a saturation of 90%. If you look at this point, the oxyhemoglobin dissociation curve beyond this point starts to getting plateaued. In other words, by increasing partial pressure of arterial oxygen, saturation wise, we are not gaining a lot. That is why we keep a saturation target of 92 to 94%, not 99% or 100% in oxygen therapy. This is the best compromise. Why is it very important to increase the oxygen flux? That is to deliver oxygen to the patient's tissues. Oxygen flux depends on the cardiac output and the oxygen content. Oxygen content in turn depends on the hemoglobin percentage and percentage saturation into the constant. By oxygen saturation, improving oxygen saturation, we try to improve this part. Now don't forget, improving somebody's oxygen up to hemoglobin percentage up to normal levels also plays a big part when the oxygen flux is concerned.
Oxygen cascade is diagrammatic representation of step down of partial pressure of oxygen from atmosphere to cellular level. So by supplementing oxygen, what we try to achieve is to increase the partial pressure of alveolar oxygen. That's the partial pressure of oxygen at this level. Oxygenation goes hand in hand with ventilation. That is the reason why I included this slide to my presentation. What is ventilation? Ventilation is movement of air through the conducting passages between the atmosphere and lungs. How to assess? By respiratory rate. Generally considered for any respiratory rate above 35 is considered for ventilatory support. By work of breathing. Nasal flaring using sternocleidomastoid or thoracoabdominal dysynchrony says that the patient is having increased work of breathing. If you do an arterial blood gas, PaCO2, arterial partial pressure of carbon dioxide, which is normal in 40, if it goes above 45, that means ventilatory support has to be considered. So, even normal PaCO2, partial pressure of arterial oxygen with high work of breathing, needs ventilatory support. Administration of oxygen. To administer oxygen, there has to be a source of oxygen as well as a delivery system. Where do you get oxygen from? We have oxygen in cylinders. That is how most of the wards gets oxygen supply. And we have a pipeline system. Usually these pipeline systems are supplied with oxygen manifolds and liquid oxygen plants. Irrespective of the source of oxygen, pressure is reduced to just above the atmospheric pressure at the outlet of the oxygen delivery. Therefore, there has to be a pressure regulator and a flow meter in between oxygen source and the outlet. When delivery systems are concerned, there are two delivery systems, variable performance divisor and fixed performance divisors. This is an oxygen cylinder. At a glance, you can say that it's an oxygen cylinder because it's color-coded. Black body and a white shoulder. This is an oxygen regulator. It reduces oxygen pressure in the oxygen cylinder and then it delivers to the oxygen flow meter. This is the flow meter. The flow meter can range from 15 liters to 60 liters and this is the humidifier bottle. The water in the humidifier bottle has to be changed every 24 hours and this is where your oxygen delivery system is connected. This is the outlet. The gauge pressure here indicates the oxygen content within the cylinder. There is a guide for availability of oxygen. How do you calculate oxygen content of a cylinder? Oxygen content of a cylinder is equivalent to the cylinder volume multiplied by the cylinder pressure. In a jumbo cylinder, there is a volume of 47 and its oxygen is stored under a pressure of 137 bars. So it contains 7,200 liters of oxygen. If you take a type D cylinder, those are the types of cylinders you find in wards. It has a volume of 10 liters and it contains 1,400 liters of oxygen. Type E cylinders, these are the cylinders you find in anesthetic machines, contain 720 liters of oxygen in a cylinder. So how long can each of these cylinders be used? For example, how do you calculate it? Usable duration of a cylinder, that is oxygen content divided by the flow rate. So, for example, if you use oxygen at a flow rate of 15 liters per minute, full jumbo cylinder can last only 480 minutes. That means 8 hours. So, to provide a man who needs 15 liters of oxygen per minute, we need 3 jumbo cylinders a day. If there's another man who needs an oxygen flow rate of 60 liters per minute, each jumbo cylinder lasts 120 minutes, that means 2 hours. And to provide oxygen for that particular person, we need 12 jumbo cylinders a day. So we have to always consider availability of oxygen when you consider methods of supplementing oxygen. Let me tell you about the status of oxygen availability in this hospital. This hospital, Provincial General Hospital Kurunegala, has 450 jumbo cylinders with a buffer stock of 30. They have 310 D cylinders and 70 E cylinders. In a non-COVID period, oxygen demand is 70 jumbo cylinders plus 30 air cylinders. Usually, 1 lorry load of oxygen a day is provided to this hospital, which carries around 100 cylinders per day. This period with COVID, 2 or more lorry loads has to be provided per day. So you can imagine the demand of oxygen on this hospital. Again tells you how much oxygen is used. Oxygen cylinder. When an oxygen cylinder is concerned, there is a pressure regulator and flow meter, and irrespective of the cylinder pressure, delivered pressure at the outlet is same. It's just above the atmospheric pressure. The flow meter of the cylinder can range from 15 liters to 60. Oxygen key is a very important thing when oxygen delivery is concerned. If you lose the oxygen cylinder key, you may not be able to get oxygen, and this can jeopardize somebody's life. And humidification is important because oxygen is stored under dry conditions. Oxygen delivery systems. These are the delivery systems that I'm going to talk in a short while. Nasal trunks. The patient is provided with oxygen using nasal trunks. Patient looks very comfortable. FiO2 depends on flow rate and the minute volume of the patient. There is no reservoir. In fact, the nasopharynx of the patient acts as the reservoir, and there is no free breathing. Depending on the flow rate that we provide, percentage of oxygen provided is determined. Remember, this is not a fixed performance device. So these values that I have mentioned are just rough calculations. Hudson mask. This is the ordinary face mask that we come across in ward. Maximum FiO2 to be delivered with this device is 60% if you give a flow of 10 liters per minute. To prevent rebreathing, minimum flow of 5 to 6 liters per minute is needed. This is also not a fixed performance device. Venturi mask. These are fixed performance devices. Irrespective of breathing pattern of the patient, they are capable of delivering constant concentration of oxygen up to 60%. There occurs no rebreathing, can provide wide range of concentrations from 24% to 60%. No need to fix the mask tightly, color coded, but coding is not standard. These are Venturi devices. Venturi devices use the Bernoulli principle, and it entrains air to these orifices and provides a flow rate that exceeds peak inspiratory flow rate of the patient, so that these devices are capable of giving constant concentration of oxygen to the patient. This man is wearing a Venturi device and venti mask and getting fixed concentration of oxygen. Non-rebreathing mask. Using a non-rebreathing mask, higher concentration of oxygen can be delivered. It has one valve. It has one-way valve. Some have two one-way valves. If you provide 10 liters per minute flow of oxygen, patient gets a fraction of inspired of oxygen concentration of 60 to 70%. If you provide 15 liters, it can be increased up to 70 to 100%. In fact, if the mask is nicely fitted, we might be able to achieve even a little higher concentrations of oxygen. But if your non-rebreathing mask is working correctly, that means it's nicely fitting the patient, the bag should be inflated, and when the patient breathes in, it should collapse. Otherwise, it is not fitting the patient properly. High flow nasal oxygen therapy. This is high flow nasal oxygen therapy. This device consists of tubing system which is thicker and wider. It has a humidifier and a regulating device, and oxygen source is connected here. When we use this method, we can provide higher concentration of oxygen at a fixed rate to the patient. We commence with a flow rate of 15 to 30 liters per minute flow rate, and we escalate it gradually up to 40 to 60 liters per minute. Consider using this intermittently. It provides a peak of 7 to 8 centimeters of water provided the mouth is closed. It helps to clear the carbon dioxide. And as it's using high flow rates, we should check the hospital capacity of oxygen supply. How does this device provide constant high concentration of oxygen to the patient? That is by providing a flow rate higher than peak inspiratory flow rate to the patient. So, if you are to get 70% oxygen to the patient, you have to provide a 40 liters per minute flow. But if you can remember your non-rebreathing mask, with 10 to 15 liters of oxygen flow per minute, we can achieve same concentration. So that if what you want is just mere supplementation of oxygen, your non-rebreathing mask may be a more economical alternative to high flow nasal oxygen. This is CPAP, continuous positive airway pressure. Initially I said once oxygenation can be improved by increasing the partial pressure of alveolar oxygen. Second, by increasing the alveolar capillary membrane available for gas exchange. Both these functions can be achieved by using CPAP. We start with a CPAP of 7 to 10 centimeters of water. For CPAP machines with single circuit, we use viral filters with non-vented mask. Viral filters should be placed between the mask and the exhalation port. Dual circuit can be used with non-vented mask and viral filters. One very important thing with CPAP is it should be a tight fitting mask. Otherwise, the mechanism does not act properly. Somebody who is on CPAP, if gets exhausted, that means patient's work of breathing increases. That indirectly tells you patient needs something more than just oxygen supplementation. What is more needed is the ventilatory support. In that case, go for pressure support, PEEP with pressure support, or for BiPAP. Let me summarize all the practical points that I have said so far. When you give oxygen therapy, please target saturation between 92 to 94%, not 98 or 100%. Use minimal FiO2 possible to achieve target saturation. Frequently monitor and adjust FiO2 accordingly. Up to 40% oxygen can be provided with nasal drums. 40 to 60% of oxygen can be used with Hudson masks. 20 to 60% of oxygen can be provided with venti mask. More than 60% of oxygen can be provided with non-rebreathing masks. Remember, nasal prongs or Hudson masks are not fixed performance devices. the FiO2 it delivers can vary with the patient's breathing pattern. If oxygen requirement increases rapidly, consider CPAP so that you can give not only oxygen supplementation but you are recruiting alveoli as well. Oxygen supplementation with high work of breathing needs BiPAP or high flow oxygen therapy. Thank you.
Kidneys and COVID-19. My name is Dr. Nalaka, Herath, consultant nephrologist. Objectives. To understand the acute kidney injury is an important complication. 3 case-based discussions to understand some key concepts. Let's move to question 1. Which of following is wrong about acute kidney injury in COVID-19? Proteinuria and hematuria seen up to 40% of patients. 1 in 3 patients develop AKI. Majority of AKI can be detected on the day of admission. Patients who develop AKI likely to have hypertension, diabetes mellitus, or congestive heart failure. Prognosis is good in victims of AKI. The wrong answer is prognosis is good in victims of AKI. Let us learn some important aspects of acute kidney injury in COVID-19 patients. As you can see here, the proteinuria is seen up to 40% of patients, followed by hematuria and acute kidney injury. It is about 30% of total patients who develop COVID-19 infection. It is a high number, and then it is important to know and diagnose acute kidney injury early. It is important to have a timing of acute kidney injury in relation to COVID-19 infection. These 2 studies demonstrate clearly the timing of or onset of kidney injury in relation to the admission of the patient. Both showed it is very early complication of COVID-19 infection. So as you can see, soon after admission, you see the patients diagnosed having acute kidney injury. The numbers coming down gradually up to day 7, and you can see there's a second peak starting from 2nd week onwards. The mortality. The mortality among hospitalized patients with COVID-19 associated acute kidney injury is higher than for those without kidney involvement, starting from 35% up to 80%. The mortality among patients admitted to ICU with COVID-19 acute kidney injury requiring renal replacement therapy is especially high, starting from 75% up to 90%. So what did you learn from these first questions? Acute kidney injury is an important complication of COVID-19 infection. It is very common. 1 in 3 patients develop acute kidney injury. It is early feature, can be detected on admission. Therefore, patients should be screened for kidney involvement on admission with urine full report and creatinine. We should pay adequate attention to correct hypovolemia, hypotension, and avoidance of nephrotoxic medication from admission. Regular monitoring of urine output is mandatory in diagnosed cases. Let's move to question number 2. An elderly woman with chronic kidney disease stage 3B, hypertension, and type 2 diabetes. Her baseline serum kidney is 145, well-controlled blood pressure, and sugar. She's on AC emitter and metformin. Presented with shortness of breath, cough, complained of poor oral intake for 3 days. And she also complained low urine output. On admission, her blood pressure was low. She's tachycardic with normal lung basis. Rapid antigen test was positive for SARS-CoV-2. Which of following is wrong answer? Stop ACE inhibitors and metformin. intravenous hydration with crystalloid, insertion of urine catheter and regular monitoring of urine output, intravenous furosemide, urgent blood gas analysis. The wrong answer is intravenous furosemide. What did you learn from this case? The blood pressure, the markedly influences renal outcome of patient with chronic kidney disease. The lower limit of normal blood pressure is mainly depend on the age and the comorbidities of the patient. It is not just the map of 60 in all patients. Good urine output without furosemide indicates adequate renal perfusion. Furosemide could only be considered in fluid overload patients. Let's move to final question. 42-year-old patient who had live donor renal transplant 11 years ago, presenting with generalized malaise, fever, body aches and pain for 3 days. On examination, having low blood pressure and tachycardia. He's on prednisolone, mycophenolate mofetil, tacrolimus and losartan. Rat is positive for COVID-19. Which of following is describe the best early intervention? Withhold MMF, withhold MMF at tacrolimus, withhold losartan, adequate fluid resuscitation with crystalloid, discuss the management of patient with nephrology team urgently. The most appropriate answer is discuss the management of patient with nephrology team urgently. What did you learn from this case? There is no clear guideline exists for the management of patient with COVID-19 with organ transplant. Reduction of or stopping immunosuppression is crucial and should be individualized. Proper isolation is important with adequate medical and nursing care. It is always important to discuss the adjustment of immunosuppression and other drugs with nephrology team as soon as possible. Dear doctors, in summary, proteinuria and hematuria seen up to 40% of patients. 1 in 3 patients develop acute kidney injury. It is so common. Majority of AKI can be detected on the day of admission. Patients who develop AKI likely to have hypertension, diabetes, and chronic heart failure. We should pay more attention on patients having hypertension, diabetes, and chronic heart failure and promptly diagnose acute kidney injury. Prognosis is poor with high mortality. Simple early interventions like improved hydration, stopping nephrotoxic medication, and monitoring reduces the morbidity and mortality. It is always important to involve the nephrology team for the optimal management. Thank you for your attention.
Welcome you all to the symposium on COVID-19 management, which is organized by Kurunegala Medical Association. I am Dr. Tharanga Rathnayaka, consultant resident physician attached to a Provincial General Hospital, Kurunegala. I am going to discuss few cases which we find day to day in COVID-19. So my first case is a 68-year-old male patient presented to the A&E with fever and cough for 7 days. He's a diagnosed patient with diabetes, hypertension, and COPD. His blood pressure was low with 96/60 and saturation was 95% on room air, and he was tachycardic, and random blood sugar was 210 and the BMI was 24. He was on several medications including losartan, amlodipine, metformin, gliclazide, and MDI inhalers. After the initial assessment, he was transferred to the COVID specified unit. His initial investigation showed hemoglobin of 12.5 and white blood cell count was 4.5 and platelet count was low with 135. CRP was 96 and SGOT-PT was 45/31 and creatinine was 135. The cutoff value was 115 and ECG showed sinus tachycardia. How do we approach this patient? So there are a few clinical problems. The first problem is low blood pressure, then uncontrolled diabetes and renal impairment, which may be acute kidney injury or AKI or CKD. Therefore, we have to know about the baseline serum creatinine value. His saturation was marginally low in the background of chronic obstructive pulmonary disease. And on top of all these, he's having COVID infection. How do you approach this patient's management? So first of all, we have to stop all the antihypertensives because he is having low blood pressure, and we have to hydrate him appropriately. And we have to stop metformin because metformin can cause a lot of problems in critical ill patients, and we have to start the patient on insulin. And target blood sugar should be in between 120 to 180. So how do we manage his diabetes? Preferably, we have to start the patient on basal bolus regimen. So total insulin requirement in a patient is usually 0.5 units per kg. And out of this total requirement, we have to give 50% as basal insulin and remaining 50% as short-acting insulin to cover each meal in 3 divided doses. So when we talk about basal insulin, we are usually using isopain insulin as a BD dose because other long-acting insulin preparations are not available in our setup. If you are using long-acting insulin, we can give it as once a day dose at 10 p.m. So these insulin preparations are insulin detimer, degludac, glargine, and Lantus. Apart from that, we have to monitor this patient closely with oxygen saturation, blood pressure, and input-output. Next day, patient became breathless and saturation dropped to 92 to 94% on room air. So what are the possibilities in this patient? We have to consider about exacerbation of COPD, and the other possibility is a pneumothorax in the background of COPD and COVID pneumonia. And it can be pulmonary edema, which can be secondary to acute myocardial infarction or a diastolic dysfunction. And we should not forget about pulmonary embolism because COVID infection is a prothrombotic condition. So how do you initially manage this patient? You have to manage as a COPD exacerbation. So we have to nebulize the patient with salbutamol 4 hourly and SOS and ipratropium bromide 6 hourly. And we have to give steroids as per COPD guidelines. So if it is oral prednisolone, it should be 30 milligrams per day, or IV hydrocortisone 100 milligrams 6 hourly. While doing all this initial management, we have to arrange necessary investigations. So urgently, we have to arrange chest X-ray, ECG, troponin, D-dimers, full count, and CRP. If patient is not improving, definitely we have to go ahead with the arterial blood gas because we want to differentiate what sort of respiratory failure this patient is in. So what are the types of respiratory failure? It can be type 1 respiratory failure where you get CO2 washout, and it can be type 2 respiratory failure where you get CO2 retention. If there is carbon dioxide retention, then we have to go for a low target oxygen saturation. So we can allow 88 to 92%, whereas if it is type 1 respiratory failure, we have to maintain oxygen saturation above 94%. And if it is type 2 failure with CO2 retention, we have to consider early NIV. So that is not CPAP, we have to go for BiPAP. Our patient continued to deteriorate. It was in illness day 8, and he was tachypneic and pulse rate was 130, and D-dimer came as more than 1500, and there was rise in CRP with value of 190, and chest X-ray showed bilateral basal and mid-zone infiltrates extend into peripheries, which is most suggestive of COVID pneumonia rather than heart failure. So this is his chest X-ray. So usually in COVID pneumonia, we get bilateral, subpleural, and peripheral involvement. In comparison to heart failure, where you get bat wing appearance, that is mainly bilateral hilar shadows. When we talk about the severity of illness, we can categorize the disease. So it can be asymptomatic patients where you don't get any symptoms except positive COVID PRAT or PCR. And then comes the mild disease where they get typical flu-like symptoms with mild cough or upper respiratory tract symptoms. And if you do a chest X-ray, it will be normal. In moderate disease, they get chest X-ray features, but saturation is more than 94%. In severe disease, patient is in respiratory failure. So saturation drops below 94% on room air, and respiratory rate is more than 30%. And if you do a chest X-ray, you might see more than 50% pulmonary involvement. In critical illness, you get definite respiratory failure, and patient might be in septic shock or multi-organ dysfunction. And if you divide the disease into phases, incubation period is usually 2 to 14 days, and viremic phase is 1 week, and then in the second week after patient developing symptoms comes the early inflammatory phase, and third week is secondary infection phase, and fourth week is multisystem inflammatory phase. So our patient is in day 8, which is compatible with early inflammatory phase. So how do you manage this patient? We have to start with triple therapy. So we are giving antibiotics for possible secondary bacterial infection to keep our patient safe. And we have to start patient on steroids and enoxaparin. And we have to give oxygen according to the target oxygen saturation. So what is the preferable steroid? So we have to use dexamethasone according to recovery trial. It has shown mortality benefit and shortens the duration of hospital stay as well. Dose is 6 milligram daily, and duration should be minimum 5 days and maximum 10 days. If you give dexamethasone beyond 10 days, there is no mortality benefit, and it will do more harm rather than doing any good. So dexamethasone is only given for patients who require oxygen. That is for the patients in severe disease. Unnecessary steroids can lead to secondary infections, especially fungal infections. COVID-19 is a prothrombotic state. So there can be microthrombi formation. Therefore, we had to use enoxaparin. And they are in very high risk for pulmonary embolism as well. Dose of the enoxaparin depends on the renal functions. If patient is having normal renal functions, in patient with moderate disease, we should give 40 milligrams once a day. And if it is severe disease, we should give 40 milligrams BD. If there is evidence of pulmonary embolism, we have to go for full treatment dose, which is 1 milligram per kg twice a day. And usually we do not go beyond 60 milligrams BD. If patient is having impaired renal functions, for moderate disease, we are giving 20 milligrams. And for severe disease, we are giving 40 milligrams once a day. And if there is evidence of pulmonary embolism, we have to give renal adjusted treatment dose, that is 1 milligram per kg subcutaneously once a day. If patient is having severe renal impairment, it's better to consider heparin infusion with close monitoring of APTT, because if patient bleeds, we can revert bleeding with protamine sulfate. So now what is the problem in our patient? Patient is deteriorating with increasing oxygen demand and work of breathing. So what are the differential diagnoses? It can be pneumothorax, it can be pulmonary embolism, it can be COVID viral pneumonia, it can be ARDS, which is secondary to cytokine storm, and it can be even pulmonary edema, maybe acute MI, maybe diastolic dysfunction, and it can be secondary bacterial infection as well. So how do you differentiate these? So you have to do ECG, troponin, urgent inward chest X-ray, full count, CRP, procalcitonin, LDH, serum ferritin, and ABG. And we have to escalate oxygen therapy appropriately. So then comes tocilizumab. Is this patient is a suitable candidate for tocilizumab? Tocilizumab is a monoclonal antibody against interleukin-6, and it has proven benefit, and it has 14% reduction in 28-day hospital stay and mortality. And it has very narrow window of treatment, therefore should be used in only selected patients. So these are the inclusion criteria for tocilizumab. Patients should be hypoxic with rapidly increasing supplementary oxygen demand, and there should be worsening radiological changes not explained by heart failure or bacterial sepsis. And the patient should have either completed or currently on steroids. And CRP should be more than 75 or doubling of CRP within last 24 hours period. And that CRP value should not be taken in isolation. Another thing is there should be D-dimers more than 1000, ferritin more than 700, and LDH more than 300. And there are several contraindications, including acute TB, herpes zoster, sepsis, GI perforation, multiple sclerosis, allergy to tocilizumab, and derangement of liver functions more than 5 times the baseline, and platelets less than 50,000, and severe neutropenia. And the dose should be 8 milligrams per kg, and maximum dose should be 800 milligrams, and it can be repeated after 12 hours. So then I would like to move to the second case, and this time it is a 55-year-old woman with type 2 diabetes, dyslipidemia, and hypertension for 15 years, presented with fever for 3 days duration and shortness of breath. She was breathless and dehydrated with ongoing temperature. Blood pressure was slightly low and tachycardic, and saturation was normal, 98% on room air. Random blood sugar was 372, and COVID-19 rapid antigen was positive. Then patient was moved to the COVID unit after initial assessment in the A&E. She was managed as COVID pneumonia with antibiotics and enoxaparin, and the patient was started on insulin basal bolus regimen. And despite above management, she became more breathless and drowsy. And subsequently, ABG was arranged by the medical SHO, which showed severe metabolic acidosis with hypokalemia and marginal raised lactate. What is the diagnosis? So this patient is having diabetic ketoacidosis in the background of COVID infection. And patient was not hypoxic, and therefore it is not COVID pneumonia. Patient was breathless due to severe metabolic acidosis. So in this sort of patients, we have to start the patient on insulin infusion, that is 0.1 units per kg per hour, usually 6 units per hour in an adult. And you have to give IV fluids with potassium replacement, and we have to start the patient on DVT prophylaxis to prevent thrombosis. So in this case, what is the take-home message? So any breathless diabetic patient with COVID, we should not forget diabetic ketoacidosis. And if patient is breathless, breathlessness is incompatible with the chest X-ray findings and oxygen saturation, we have to always think about diabetic ketoacidosis, because outcome will be very, very poor if we could not manage these patients early. So let's move to third case. A 44-year-old woman with long-standing history of diabetes presented with cough, fever, and shortness of breath for 5 days. Blood pressure was normal, and she was tachycardic, but desaturating with saturation of 85% on room air and tachypneic. Chest X-ray showed classic COVID pneumonia changes, and it was diagnosed as severe COVID pneumonia, and patient was moved to ICU as increased work of breathing and oxygen requirement. She was on standard COVID pneumonia regimen and was slowly improving. After 10 days of ICU stay, she developed double vision. On examination, there was right complex ophthalmoplegia with mild periorbital swelling and chemosis. Subsequently, the other eye was also involved, and patient became very unwell with high inflammatory markers. After 2 days, there was paralysis of right face, arm, and lower limb, which was compatible with right-sided CVA, and NCCT brain showed massive left MCA infarction. What are the differential diagnoses? So we have to think about cavernous sinus thrombosis, and the other possibility is invasive fungal infection, which has very high mortality. So in this patient, the diagnosis was invasive fungal infection, which was mucormycosis. Mucormycosis is potentially lethal if not attended early, and it leads to devastating rhino-orbital cerebral infection, and characterized by infarctions and necrosis of host tissue that result from invasion of vasculature by hyphae. Therefore, it invades along the vasculature. And these sort of patients need urgent ENT surgical interventions to drain. So we can go ahead with FES, that is functional endoscopic sinus surgery. And treatment is amphotericin B. So what is the take-home message here? So any patient, COVID patient with eye swelling, especially in the background of diabetes, we have to always consider the possibility of mucormycosis. And if you notice this sort of patient, you should seek urgent senior attention. And these patients need to be started on amphotericin B as soon as possible. So this is the end of my presentation, and I would like to thank all of you for your patient listening. Thank you very much.